My name's Emma Redfern and I'm a consultant in the emergency department at the BRI. I've also got a trust-wide safety role, and I'm really delighted to see in the audience tonight some of my colleagues that I've previously worked with in safety at UHB. I've been asked to talk about two questions tonight. The first, how do medical professionals at the sharp end ensure high-quality services? And the second is about regulation and whether that's helpful. So the sharp end for me is the emergency department. For those of you who've ever attended the emergency department, either as a patient yourself or with your friends and family, will know that it's busy, complicated, and often a crowded environment. At the Bristol Royal Infirmary, on the adult side of the department, we see about 200 patients a day and another 80 on the children's side. We see the full range of medical diagnoses. We see some very sick patients. We deliver the full spectrum of medical care in terms of from treating broken bones up to treating patients who are in cardiac arrest and everything in between. Our lights are on 24 hours a day. I've got junior doctors working there all night. And the very nature of what we do in the emergency department comes with an inherent risk. And it was that risk that first sparked my interest in patient safety, with an aim to try and improve the situation. So how do we ensure safety on the shop floor? Well, firstly, the basics have to be right. We've got to have well-trained, competent staff. We need to implement best practice guidelines. We need to have an IT infrastructure that helps the delivery of care. We need rigorous infection control procedures, and we need rapid access to diagnostics. But that's not all. So patient safety problems exist in the NHS just as they exist in every healthcare system across the world. We know that about 1 in 10 patients will suffer an adverse event on admission to hospital where the care hasn't really gone according to plan, and about half of those are preventable. Thankfully, in most cases, no harm is actually caused to the patient, but occasionally errors can occur where major harm is caused. And the willingness of our staff to freely report adverse incidents, in particular the near misses where we can learn the most, is a prerequisite to safe healthcare. I was lucky enough to work with Charles Vincent when he was at the Imperial College in London as a professor of safety. And he taught me that clinical incident reporting is like a window into your service, and it's especially important when you're not there. And I remember my first on-call at the BRI, sort of an overnight on call. We start on the shop floor about 4 o'clock. We help the juniors make decisions. We see patients ourselves. We get involved in manipulations of joint fractures, anaesthetising patients for CT scans. And around about 10:30 at night, we hand over to the junior team, and there's no consultant then present on the shop floor. And I go home and do my on-call from home. And I'd spoken earlier in the day to the Professor of Emergency Care in my department, Jonathan Benger, and I'd said that I was finding the weight of responsibility of being a consultant quite daunting. And he said to me, it's really when you're not there that you need to worry. And as I drove away from the hospital that first night, going home, this message really hit home. And I started thinking, are the junior staff really well trained enough to deal with everything that we might throw at them? Have we got clear enough guidelines? Can they find them? Do they know where they are at 2 o'clock in the morning? And is the department going to get overwhelmingly busy and that the junior staff won't be able to cope? And it's fair to say that the first night I was on call, I didn't really have any sleep because I was so worried about what was going on when I wasn't there to help. And unless adverse events are recorded, we can't actually tackle the system that led to the event happening in the first place. The organisational culture needs to be developed to make incident reporting the absolute norm. And the NHS staff are almost certainly not to blame for when things go wrong. In the vast majority of cases, the system, the conditions, the environment and the constraints have led to the patient safety problems. Once we've identified the problems, we really need to learn from what's happened and make changes to make things better. Not just at an individual level, not just at a department level, but sometimes at regional, national and international levels. Within our teams, we need really strong clinical leadership to ensure that the members of staff understand why we're asking them to change and encourage people to change their practice and sustain it. When stories of things that have gone wrong are the most powerful drivers of change, and what we need to get to is a situation where the way we do things around here is the safe way, Everybody, including the nurses, the doctors, the porters, the receptionists, understand why we're doing something a certain way and adhere to the rules. So some examples of improvements in safety. The risk of death associated with having a general anaesthetic in the 1980s was about 1 in 10,000, and that was considered a relatively safe procedure. But critical analysis of when patients had died due to an anaesthetic showed that it was most likely due to a low oxygen level, and that was usually because the tube, the breathing tube that you were placed on the ventilator, was put in the wrong place. And the introduction of an oxygen saturation probe, which is a really cheap, simple piece of kit, and standardisation of anaesthetic guidelines led to safer anaesthetics and the reduction in harm by 20 times. And now when you have an anaesthetic, it is exceptionally rare for something to go wrong. More locally, we had an adverse incident at University Hospitals, Bristol, where a patient who'd been prescribed a medication hadn't received that medication, and this contributed to her developing a blood clot in her lung. As a trust, we collected incident reports that suggested this wasn't really an isolated event on one ward, but it was happening across the trust. And in July 2012, we commissioned the pharmacy team to undertake an inspection of every single drug chart in the trust. That's 641 patients and just under 10,000 doses of prescribed medication. And we found that about 4% of medicines that were prescribed were not given, and there was no documented reason for that. So we launched a trust-wide focus. We made simple guidance for our nursing staff. We involved the medics to check that the drugs that they were prescribing were still relevant and still needed. The pharmacy staff fed back in real time to the nursing staff and the medical staff when delivered doses of medicines hadn't happened. And as we gained a greater understanding of what the problems were, we were able to develop an IT innovation which showed the wards where drug stocks were out of hours. So if they didn't hold that drug on the ward, they could go and find another ward that did and get that medication to the patient. We collected monthly data and we fed back to the team. In September 2014, we've just repeated the review. We looked at 868 prescriptions and only 6 doses were omitted. That's 0.7%, an 80% reduction. It's not been plain sailing all the way. We've gone up and down as wards have struggled with particular groups of patients and particular medications. We're still carrying on trying to reduce that, and we won't really be very happy until we get to naught. So in summary, in terms of delivery of safe care, you really do need a well-functioning basic infrastructure. But more importantly, at organisational level, reporting adverse incidents needs to be normal, and the workforce needs to accept the need to learn and change practice to improve the delivery of care. The second question about regulation: does regulation help ensure high-quality clinical standards? So for obvious reasons, healthcare has to be heavily regulated, and we have lots of regulators. So the CQC will look at our quality and safety. Monitor will look at our finances and our performance. And the General Medical Council regulates the code of good practice for all doctors and ensures that all doctors are revalidated as fit to practice every 5 years. There's no doubt that the introduction of qualitative performance targets has driven up the quality of care. And achievement of the targets, such as the 4-hour target in the emergency department, has vastly improved the waiting time and the length of time that you spend in the emergency department for most patients. When I was a junior, starting in ED in 2004, I would do my night shift, I would leave at 8 o'clock in the morning, and when I returned at 8 o'clock at night, the same patients would still be on the trolleys, and there would be a 12-hour wait to be seen for the new patients, and that's something I've not seen since 2006. But we need to make really sure that the targets are used to assist the delivery of care and make certain that as clinicians, the delivery of the target doesn't become the priority. We've just had our CQC inspection. They looked at the 5 domains. So the safety of our care: is it caring, is it responsive, is it effective, is it well led? And to be honest, if I was asked to review the quality of what we deliver in the emergency department, that wouldn't be far off the mark in terms of the things that I would be looking for. The inspection was really thorough. It was undertaken by clinical staff who understood the operational issues faced by acute trusts. And we don't have the final report yet, but the assessment felt fair and it felt reasonable, and it will allow us to celebrate what we're doing well, but also to focus our mind on what needs improvement. So to summarise, I think that patient safety is at the highest profile it's ever been since the generation of the NHS, and the clinical staff really are recognising the need for change. Qualitative targets can help, but they absolutely must not be, the delivery of that target must not be the main priority. And I guess I really want to deliver greatcare.com, and the teams really are striving to do that, and I think we're seeing a period of real change. Thank you.